The essentials of examining a neuropathy patient is to determine whether they have neuropathy due to metabolic disorders, things like diabetes, or they chemo-induced or statin-induced. And there's other things too that come into play, heavy metal toxicities, nutrient deficiencies, and so forth. You want to be able to determine, is the neuropathy from one of those, or is it a compressive type neuropathy? So follows is the detailed exam that I give to all my neuropathy patients to help me sort through some of those and determine the level of the severity of the neuropathy and whether it's a case that we can feel confident in taking on and likely help. So the first thing we do in our office with all of our new patients for all of our niches is we have them do a digital weight-bearing foot scan of both of their feet. So my son Noah has volunteered to show off a little bit here. Noah, will you stand on the scanner? And we're not actually going to scan his feet here, but what the importance of this is it will show how they bear weight from side to side. It'll show if they have any asymmetry in their arch height side to side, because what do neuropathy sufferers have problems with a lot of times? It's balance. So this will show how they are balanced, what those arches are doing, and how their feet may be affecting other areas of their body. So an important and a good part of an examination is to do a standing bilateral weight-bearing foot scan. The other thing with the foot exam that we start with, if you don't have a foot scanner in your office, it's a good idea to just simply screen for what are called the 5 red flags of pronation. It's the most common postural distortion in the human body, and almost all of your niche patients that have neuropathy, knee pain, or low back pain are going to have pronation. So what are the 5 red flags? Well, number one is external foot flare. So you would see the patient walking or standing with their feet flared out. That is a cardinal sign of excessive ankle pronation. Back to the neutral position here, you need to you should be able to stick a couple fingers under those medial arches. If they have dropped medial arches, that is a red flag of pronation. Turn around, face that way for me for a moment. You always look at them from the back. The pronated patient will have what they call bowed medial Achilles tendons. Turn back around now. And if they have that, if they have excessive pronation, almost always you will find that their kneecaps are rotated inwardly. And then the final sign is look at their shoe wear. Look at the outer sides of their shoe, the lateral aspects of them. Most of the time, the pronated patient will have lateral heel wear, usually one side more than the other. In other words, they have bilateral but asymmetrical pronation. Those are the 5 red flags of pronation to screen for in all of your patients. When examining your patients, you want to create a really good flow so that you don't have to keep the patient moving from position to position and then have move back to a position when you should have gotten all your tests done in that position in the first place. So do your standing tests, then do seated, and then do supine, and then do prone tests. So make sure you get all your tests done in whatever the position is in so that it's smooth, it's efficient, and the patient doesn't have to move any more than necessary. Remember, when we're dealing with neuropathy, they may have compressive neuropathy from their lower back. And so a couple simple standing tests to do with these patients is one, check their range of motion and do chems tests. So face that way, Noah. I always just do, I don't measure range of motion usually, but I always have checked the major motions to see are there any restrictions or increased pain, and then note them in my exam. So Noah, twist to the left to what you can, twist to the right to what you can, and you always ask any extra pain. And bend to your left, bend to your right, observing to see if there's any restriction or pain or guarded movement. Bend back as far as you can, and then bend forward like you're trying to touch your toes. Quick screen, note in your exam any limitation of motion and if there was any pain with those movements. And then also do a simple Kemp's test. No, I'm going to bend you to your right. I'm going to twist you and I'm going to bring you back. Ask if that increases any back or radiating symptoms down either leg, and then repeat to the other side. Important, simple, quick screens to see if there's anything going on with the low back that might be contributing to their neuropathy. I'm now going to go on to the seated exam of the neuropathy patient. So just a few simple tests to quickly perform here. Obviously, we want to check reflexes with a neuropathy patient, neurological condition. So we would check obviously the patellar reflex and the Achilles reflex, looking for asymmetry from left to right. That's the big thing. And then finally, rule out any signs of potential nerve compression or nerve root tension signs. So do a simple Becker-Roos test. Straighten the right leg, Noah. Does that, ask the patient, does that in any way increase any low back symptoms or anything down the leg? If not, add in a little more stretch to the nerve root. Noah, tuck your chin. Lean forward a little bit. You're going to feel a really good pull right here. This is slump test. And if there's something going on with the nerve root due to compression, like a disc, that is one of your most sensitive tests to bring it out. Obviously, you would do that bilateral. And finally, Noah, bring both legs up, tuck your chin down, take a deep breath in, and hold it and bear down like you almost were trying to have a bowel movement. Good. Combining tests like double Becker-Roos with the slump and a Valsalva maneuver. If there's something compressing in the low back, the combination of those three tests will bring it out. So start with the least invasive and gradually move up to see if you pick up any signs of nerve root tension. Those are your basic seated tests. We've now shifted the patient to the supine position. You want to finish up. We started the reflexes, so you definitely want to go to motor examination to see if there's any nerve root compression that might be affecting motor. So feet in, hold them now, don't let me push them back out. Good, let them go out. Don't let me push them back in. Good, big toes up, don't let me push them down. You screen for the three most common nerve roots that are compressed in the lumbar spine, L4, L5 with the big toe, and S1. You would also want to do a sensory exam, double pinwheel. So you're going to feel a little prickly sensation here. No, it should feel equal from side to side. And so you ask the patient, does that feel roughly the same? L4, and then the big toe. Does that feel roughly the same? There's L5 and outer ankle S1. You quickly screen to see is there any sensory deficit that might be from a nerve root being compressed in the low back. Again, you're trying to rule out between compressive neuropathy and metabolic, so you gotta sometimes screen for both. Then, sometimes with neuropathy, you will have peripheral nerve entrapments. In the lower extremity, there's about 2 or 3 sites that you really gotta screen for. One is in the tarsal tunnel area for the posterior tibial nerve. So you take a reflex hammer and you do Tinel's test there, and you lightly tap over that. The normal response should be they should just feel the pressure, but somebody with tarsal tunnel syndrome will feel tingling, zingy, numbness type sensations going down a lot of times into the bottom of their foot or into their big toe. Occasionally they'll feel it go up. Do that bilaterally. Then you would do a test to see if they have compression of the plantar nerve going between, or the interdigital nerve, sometimes called, in between any of the toes. So you simply do compression right at the forefoot area, squeeze with steady pressure, and ask, does that cause any pain, tingling, or numbness to go down the toes? Most commonly that compression will be between your third and your fourth metatarsals, and sometimes it's called an interdigital neuroma. Do that bilaterally. So we've screened the tarsal tunnel, we've screened through the metatarsal compression. The other side of compression you'll find is behind the fibular head. This I just simply palpate for. This would be the common peroneal nerve. And so you will palpate for a tight, taut, tender band in there. And most of the time, with people that don't have it, you'll just feel it's just nice, normal tissue. But if they have compression there, you will find a definitive taut and tender spot that'll usually you'll get a little jump sign from that. And if you do, you keep pressure there, and a lot of times you just ask the patient, when I push here, do you feel any symptoms radiating down your leg into your foot? And if they do, it's a pretty strong sign they have a compressive neuropathy of the common peroneal nerve behind the fibular head. The other area to palpate is when you find the tib-fib joint here go slightly below it an inch or two. The common peroneal nerve comes from behind the fibular head and crosses over the fibular head right in this area. And a lot of times you'll find entrapment right there too. And most people might be just a little tender, but what if it's compressed, you'll find wowzers. They really jump when you hit that. And a lot of times there'll be a trigger point there that will reproduce some of their foot symptoms. You also want to palpate the gastrocnemius about mid-belly. Occasionally there can be a nerve entrapment there. I find that one very rarely, but definitely palpate that area to see if you find a tender nodule right in the mid-belly of the gastrocnemius muscle. Those are the common peripheral nerve entrapments that you want to screen for in the neuropathy patient. Finally, finishing up one of your things with your low back pain or low back exam, do a straight leg raise test to see if that causes low back pain or any radiation of symptoms down their leg. Note the degrees in your exam. And if that does, you can always lower it and then do a Braggard's test to see if that reproduces it. Finally, we talked about the key points of palpation, the McDaddy test when it comes to diagnosing the degree of severity of neuropathy is to do what's called the Toronto Clinical Scoring System. And there are 5 tests involved. We test for vibration, cold, pinwheel, heat, and then fine touch with a monofilament. And what you're doing with this exam is you're comparing an area that's normal feeling to an area that is usually abnormal, as in the case of neuropathy. So in most people, I compare sensation in their hands to their feet. And then we score this out of 100 points. So let me demonstrate. So the first test I would do with Noah here is vibration. And so Noah, I'm going to put some vibration on your thumb, and then I'm going to put it on your big toe, and we're going to compare. When we put it on your thumb, we're going to assume you have normal sensation there, so we're going to call that the perfect 10. And then I'm going to put it on your big toe. If it feels the same as your thumb, you're going to say it's a 10. If I put it on your big toe and you just don't feel it at all, you're going to say it's a 0. And finally, if I put it on your big toe and you're like, well, yes, I can feel it, but just not as much as the thumb, then you ask the patient to give you a number between 0 and 10 to the best ability that they can. So I usually just tap my tuning fork, I put it on their thumb, ask the patient, do you feel that? Do you feel that vibrate? And usually they say, yes, I feel that. And then I'll re-tap it again and I'll put it on their big toe. And usually with neuropathy patients, what you'll see is a lot of times the vibration is one of the first things they say go on. A lot of neuropathy patients will say, oh, doc, I don't feel that at all. Or they'll say, I feel it, but just a little bit. But bottom line is you want to get a number out of them. And again, review, a 10, it's the same. A 0, it's none. And if they feel it, but just not as much, you want to get them to rate it between 0 and 10. So you do vibration, both sides, and then you would go cold. So I use just a simple cold pack, and I put that across their fingers, and then I tell them that's the 10. So we're going to compare the feet to that. Then I'll put it down on their feet, and we will compare bilaterally. And we're recording these scores. So if he told me it was a 5, we record 5 on the right, and if on the left it was a 4, we record that on the left. And we're going to add up these numbers at the end to see what their score out of a total of 100 points is. Then we go to a more sharper sensation like a pinwheel. So I usually use the thumb, and I will run that up and down and say that's the 10. and then run it on their big toe and compare. Quickly screening both sides, getting numbers, and then we do heat. So I usually have a blow dryer plugged in right close to the exam table, and I will turn that on, get it nice and warm, and then I will just blow it right across their fingers. Tell them that's what a 10 should feel like, and then blow it across their toes bilaterally. Get a number out of them, and finally we use a little device called a monofilament. And this is just for light touch or fine discrimination, and so we lightly bring it across their thumb, tell them that's the 10, and then we compare it to their big toe bilaterally. It's just very light. This is the one a lot of them sometimes with neuropathy feel very little. You'll see vibration, and this light monofilament are some of your key indicators. So at the end of that exam, you tally it up. And I always tell patients, if we see you score 20 points or higher on this exam, we got a pretty good chance of helping you. But if you score 20 points or under 20 points on this exam, it's going to be a really challenging case, and you have to have a good honest talk with the patient whether they want to really go through your neuropathy program or not. Worst one I ever saw was 3 points, and that case I did not take on, just way too much nerve damage. But this is a nice, objective, quantifiable way to determine how much nerve damage is done. Another way to do it is having an EMG, but not all patients have that. And so this is how we screen the neuropathy cases in our clinic, and then we do this exam, this Toronto exam, as we go through our neuropathy program, usually once a month for a few months till we get to the end, and most cases improve. We see their scores improve. So that's how you work up these cases in the supine position. Final position is I finish in the prone position, and I will finish my lumbar spine evaluation. So palpate the relevant anatomy that you think might be causing some potential compression. So obviously piriformis muscles are big areas to palpate. If you're thinking maybe there's some sciatic nerve involvement, palpate the lumbar muscles, the TFL, some of the other gluteal muscles, and then palpate your spine for chiropractic misalignments. And finally, there's some extra tests that you may want to consider. So I mentioned briefly the EMG, or the nerve conduction velocity. A lot of your neuropathy patients will come in and they'll have that test done already, but if you're just not quite certain, is it more of a sensory distal neuropathy, or is it a compressive lumbar radiculopathy from the lumbar spine? Sometimes an EMG can help you sort that out. You may need to consider getting a lumbar spine MRI, or even just some standing x-rays of the lumbar spine to see if there's any potential disc involvement or spinal stenosis, which would be your two major compressive neuropathy conditions in the lumbar spine. And finally, I have all of my neuropathy patients do an index called the Michigan Neuropathy Index. And it just kind of shows how their neuropathy is affecting their daily life, and it kind of helps to score the severity of it. And if you do all those things that I showed you, you'll have done a world-class workup on a neuropathy patient. You'll have a really good idea if it's compressive or if it's just straight up due to a metabolic disorder causing their neuropathy. And if you need a few extra tests, like we talked about, order those. But bottom line is, you will have one impressed patient by the end of that exam who will be much more likely to listen to your recommendations about treating their neuropathy case.